Hello, and welcome to the 48th Annual AAKP National Patient Meeting, Transforming American Kidney Health. Patients take the lead. My name is Richard Knight, and I'm honored to serve as the immediate past president of AAKP. I'm a former dialysis patient and current kidney transplant patient of 17 years next month. The AAKP National Patient Meeting is a significant platform that brings together patients, care partners, healthcare professionals, and industry leaders to exchange knowledge, foster dialogue, and collectively work towards improving kidney health and patient care. As a patient-led organization, we have increased awareness about kidney diseases and improved access to quality care for millions nationwide for over 50 years. It was an honor to represent AAKP as we engage in key policy deliberations that impact patients like you. Our work on the 2019 Executive Order on Advancing American Kidney Health and the 2020 extension of the Medicare coverage of immunosuppressive drugs are just two examples. Leading by example, other AAKP Board of Director members and I hope to inspire fellow patients across the nation and even the globe. We hope to inspire you to participate more actively in the policy decisions that impact their lives and livelihoods. AAKP is organized around the key principle of patient care choice. We believe every kidney patient has the intelligence to make treatment decisions that best align with their aspirations and dreams, including working in a career or trade of their choice, getting an education, owning a home, starting a family, and retiring securely. Patients are the most important voice and decision maker when determining health treatments. AAKP is intensely focused on disrupting status quo kidney care and bringing forward new innovations that prevent kidney failure and improve outcomes for patients whose kidneys have failed. That is why we support kidney disease research and efforts to address unmet patient needs. And this is also why we have done so much education work in the area of COVID-19 over the past 3 years. I am pleased to introduce our esteemed speakers for our next session titled Ongoing Threats to Vulnerable Kidney Patients and Current Research on Long COVID. COVID-19 continues to pose a substantial threat to people with compromised immune systems and those who are immunosuppressed, such as myself. The ongoing COVID threat to vulnerable people underscores the importance of maintaining protective measures and vigilance within the kidney community. That is why AAKP issued a formal statement last spring when the national public health emergency ended. Some claimed at that time it was a new day in America. But as kidney patients, it is not really a new day. Our lives remain at risk, and AAKP has made this point to elected and appointed leaders at every level and through our role on the CDC Health Infection Control Practices Advisory Committee, or HIPAC. In today's session, our speakers will provide updates on the virus and variants, speak to recently released data on COVID-19, highlighting what we know and what we still do not know regarding the impact on vulnerable populations, as well as look ahead on what industry is doing to help protect the individuals in our circumstances. Our first speaker is Dr. Shannon Novosad, a medical officer in the Division of Healthcare Quality Promotion at the CDC. Dr. Novosad also serves as the team lead for the Dialysis Safety Team. She came to CDC as an Epidemic Intelligence Service Officer assigned to the Division of Healthcare Quality Promotion, where she investigated outbreaks in healthcare settings. Her current areas of concentration include infection prevention, outbreak response, and surveillance in dialysis settings. I am pleased to turn things over to Dr. Novosad to provide us with a CDC update on the virus and its variants. Dr. Novosad?
Hi, everyone. Thanks so much to AAKP and Richard for the opportunity to present this information today. Today, I'm going to be talking about what patients with kidney disease can do to protect themselves from respiratory viruses. Some of the information I'm going to present will probably be a review or even common knowledge for many of you. But as we enter a new respiratory viral season, it's important that we review some of the things we can do to keep ourselves and others safe. I don't have to tell this group that these actions are particularly important for people with chronic kidney disease. Given time limitations, I'm not going to be able to discuss all topics that are important in this space. So just because I don't mention it doesn't mean it's not important. I encourage everyone to review the information available on the CDC website and reach out if there are any questions. It's common to get sick from respiratory viruses such as COVID-19, flu, and respiratory syncytial virus, also known as RSV, especially in the fall and winter. Over the past several years, you've heard a lot about what you can do to protect yourself from acquiring COVID-19. We're going to review steps you can take now to continue to protect yourself and others from COVID-19. However, it's also important to think about protecting yourself from flu, which, as you know, is a contagious respiratory illness caused by the influenza virus that infects the nose, throat, and sometimes the lungs, and RSV, a common respiratory virus that usually causes mild cold-like symptoms. Most people recover in a week or two, but in some people, RSV can be serious. Today, we will discuss whether you are more likely to get seriously ill from these viruses, how to protect against these viruses, how to determine if these viruses are spreading in your community, and available treatments if you get one of these viruses. Respiratory viruses, including COVID-19, influenza, and RSV, can affect anyone, but those at higher risk of getting very sick generally include the following: older adults, meaning those that are greater to or equal than 65 years old, people with weakened immune systems, such as following a kidney transplant, certain underlying health conditions, including chronic kidney disease, pregnant people, infants and young children, and people with disabilities, and those from racial and ethnic minority groups who may experience health inequities because of social factors. On this slide, I just wanted to highlight a recent data analysis from CDC that supports the increased risk in patients with chronic kidney disease with COVID-19. There were several findings illustrating this increased risk described in this publication, but the one I want to specifically point out involves COVID-19 related deaths. The authors examined COVID-19 related deaths in patients on maintenance dialysis and compared them to the general population from June 2021 to September 2022. They found that COVID-19 related death rate among patients on maintenance dialysis was higher in the U.S. population greater than 75 years old, which is a group considered to be at high risk of serious outcomes related to COVID-19 infection. So what are some actions you can take to protect yourself and others from respiratory viruses? You want to ensure that you and your family or caregivers are up to date with recommended vaccines. You want to be aware when respiratory virus levels are increasing in the community and understand when you should wear a mask or respirator to protect yourself. You want to know where to go for up-to-date and accurate information on recommended infection prevention and control practices, including when there are changes in response to new infections in healthcare facilities that you may visit or increases in respiratory virus levels in the community. You also want to know where to go for respiratory viral testing where you can get rapid results. For example, that means on-site testing or send out labs with the results available within 24 hours. And you want to ensure you know who to call to determine if available respiratory virus treatments or prophylaxis are indicated. We'll discuss some of these actions in more details in the following slides. Stay up to date with the immunizations that are recommended for you. For most people, recommended immunizations include a current flu shot and current COVID-19 vaccine. For older adults, young children, or those at higher risk of getting sick, additional vaccinations such as against RSV may be recommended. When possible, get vaccinated before respiratory viruses begin spreading in your community because it can take time for your body to develop protection following immunization. I'm going to start with RSV vaccines, as you may not have heard as much about these. There are currently 2 vaccines licensed for use in adults aged 60 years and older to protect against RSV infection. Optionally, vaccination should occur before the onset of the fall and winter RSV season. However, typical RSV seasonality was disrupted by the COVID-19 pandemic and has not returned to pre-pandemic patterns. So for the 2023-24 RSV season, you should get and providers should offer RSV vaccination as early as vaccine supply becomes available. Currently, the RSV vaccine series consists of a single dose. CDC recommends all adults 60 years of age and older receive a single dose of RSV vaccine using shared clinical decision-making. You should have a conversation with your healthcare provider to determine if RSV vaccination will be beneficial. This is different from routine age-based and risk-based vaccine recommendations that you may be more familiar with, where the default decision is to vaccinate all persons in a specific age group or risk group. Under this new strategy, there is no default. Rather, the decision whether to vaccinate a patient is individually based and informed by discussions between the patient and healthcare provider. The decision may be informed by a patient's health status, their risk of severe RSV disease, the healthcare provider's clinical judgment, the patient's preferences, the safety profile of the RSV vaccine products, and other factors. This is intended to allow providers and patients flexibility based on what is best for each individual patient. Of note, chronic kidney disease is included on the list of underlying health conditions associated with increased risk for severe RSV disease. There are additional recommendations for infants and pregnant women for this vaccine not covered today. Visit the CDC website for more information on these recommendations. One RSV vaccine question that we've been getting lately is, will I need another dose of RSV vaccine next year? Currently, the RSV vaccine series consists of a single dose. Studies are ongoing to determine whether older adults might benefit from receiving additional RSV vaccines in the future. So far, RSV vaccines appear to provide some protection for at least 2 RSV seasons. Additional surveillance and evaluation activities are planned to assess how long the vaccines protect against RSV and whether additional doses will be needed. The CDC website will be updated as more information becomes available. Switching gears to flu vaccine, which most of you are probably more familiar with, all people 6 months and older, with very rare exceptions, should get a flu vaccine every year. Vaccination is particularly important for people who are at high risk of developing serious complications from influenza, including people with chronic kidney disease. Different flu vaccines are approved for different groups. Talk with your provider to make sure you're getting the right one for your age and health status. Some people, for example, pregnant people and people with some chronic health conditions, should not get some types of influenza vaccines. We'll review this a bit in the next slide. There are different flu vaccine manufacturers and multiple flu vaccines that are licensed and recommended for use in the United States each year. There is no preferential recommendation for one flu vaccine over another, except for people aged greater than or equal to 65 years, which we'll also discuss in more detail on the next slide. So there are 2 ways to get a flu vaccine. The first is an injection or a shot, which can contain either inactivated or dead virus or no virus. So if there's no virus, so no inactivated virus, they contain an antigen, which is made through recombinant methods. So to describe this in a little more detail, an antigen is a part of the influenza virus that triggers the human immune system to create antibodies specifically targeting the virus. Scientists use the genes that code this antigen and produce the antigen in bulk, which is then incorporated in the vaccine. If you are 65 years and older, regardless of whether you have chronic kidney disease, 3 vaccines are preferentially recommended. The first is a high-dose inactivated, so it has higher doses of dead virus. The adjuvanted inactivated, again, it has a dead virus, but also contains an adjuvant, which is an ingredient added to a vaccine that helps create a stronger immune response. Or number 3 is the recombinant vaccine, which we just discussed. This recommendation was based on a review of available studies which suggests that in this age group, these 3 vaccines are potentially more effective than just the standard dose unadjuvanted flu vaccines. The high dose is not recommended for chronic kidney disease alone, which is a common question we get. The second option for flu vaccine is the nasal spray, which contains live virus, but it has been weakened so it will not cause influenza. It's generally approved for people aged 2 years through 49 years, but a caveat is that it's generally not recommended for people with chronic kidney disease. There's a lot that goes into these recommendations for the nasal spray, and we won't be able to get into them in detail today, but that's what we were alluding to on the prior slide where we talked about, pregnant people and people with some chronic medical conditions and which flu vaccines they shouldn't get. So if you want to review this in more detail, the Advisory Committee on Immunization Practices recommendations are on the CDC website, and again, go into more detail on who should and shouldn't get the nasal vaccine. But I'd say specific, to those people with chronic kidney disease, as I said, it's generally not recommended. And so I would definitely talk with your healthcare provider before you would receive this particular flu vaccine. So some common flu questions we get. So one is, I'm 65 years or older. My primary care office doesn't have any of the 3 preferred flu vaccines. Should I wait to get vaccinated until I can find one of these vaccines, or should I just get the vaccine now? And so if none of the preferred flu vaccines is available at that opportunity for vaccine administration, then any other age-appropriate influenza vaccine should be used. And then, is it safe to get the vaccine if I am allergic to eggs? And so the answer is yes. People with egg allergies may receive any vaccine, egg-based or non-egg-based, that is otherwise appropriate for their age and health status. And so beginning with the 2023-24 season, additional safety measures are no longer recommended for flu vaccination of people who are allergic to eggs beyond those recommended for receipt of any vaccine, regardless of the severity of the previous reaction to eggs. And so why this change? Most flu shots and nasal spray flu vaccine are manufactured using egg-based technology. Because of this, they contain a small amount of egg proteins. However, studies that have examined the use of both the nasal spray vaccine and flu shots in egg allergic and non-egg allergic patients indicate that severe allergic reactions in some people with egg allergies are unlikely. However, caveat, people who are allergic to another component in a flu vaccine should not receive vaccines that contain that component. So again, there's some differentiation there between egg allergy and allergies to other components of the vaccine. And again, it's really important to discuss any allergies, ahead of time before receiving the flu vaccine or any vaccine with your healthcare provider. All right, the third type of vaccine we'll discuss today are COVID-19 vaccines. So as you probably know, the vaccines authorized under Emergency Use Authorizations, or EUAs, are approved by biologics license applications by the Food and Drug Administration have changed over time. There are currently two types of authorized or approved vaccines, included mRNA vaccines, so that's the Pfizer and Moderna COVID-19 vaccines, and protein subunit vaccines, currently the Novavax vaccine. So just a quick review, mRNA vaccines use mRNA created in a laboratory to teach our cells how to make a protein, or even just a piece of a protein, which then can trigger an immune response inside our bodies. The mRNA from the vaccines is broken down within a few days after vaccination and discarded from the body. Protein subunit vaccines contain pieces of protein from the virus that causes COVID-19. The virus proteins are the spike proteins. So the Novavax vaccine also contains another ingredient called an adjuvant. Again, we talked about this on previous slides with flu vaccines, and remember, it helps the immune system respond to that spike protein. After learning how to respond to the spike protein, the immune system will be able to respond quickly when it sees the actual virus spike protein and protect you against COVID-19. And then two other terms I wanted to remind everyone of is the monovalent and bivalent. So monovalent means the vaccine is designed to target one virus strain. The first or original COVID-19 vaccines were designed to protect against one virus, the original virus that caused COVID-19. The original Pfizer and Moderna vaccines are no longer authorized for use by the FDA in the US. And then also the J&J or Janssen COVID-19 vaccine has expired and is no longer available for use in the US. Then you remember we moved to bivalent, and bivalent generally means the vaccine is designed to target two virus strains. So remember, both Pfizer and Moderna developed bivalent COVID-19 vaccines that protected against both the original virus and the Omicron BA4, BA5 lineage. They are no longer recommended in the US, and we'll hear about that on the next slide. So on Monday, September 11th, 2023, FDA authorized updated vaccines from Pfizer and Moderna. These are monovalent vaccines targeted at the Omicron variant XBB.1.5. The Advisory Committee on Immunization Practices, or ACIP, met on September 12th and issued recommendations on COVID-19 vaccines for fall 2023, and these recommendations were signed by the CDC director on the same day, meaning that these new vaccines can now be administered. These recommendations at a high level include everyone aged 5 years and older should get one dose of the updated Pfizer or Moderna vaccine to protect against serious illness from COVID-19. People who are moderately to severely immunocompromised may get additional doses of updated COVID-19 vaccine. And children aged 6 months to 4 years need multiple doses of COVID-19 vaccines to be up to date, including at least one dose of updated COVID-19 vaccine. Given time constraints for the presentation today, we're not able to get into the details of these recommendations, so I encourage everyone to discuss with their healthcare provider what these recommendations mean for them. You can probably tell by looking at them that depending on what your group you're in, it may get a little more complicated exactly when and how many doses of the updated COVID-19 vaccine you'll need, particularly for people who are moderately to severely immunocompromised or children aged 6 months to 4 years. So again, talk with your healthcare provider and visit the CDC website for more information. I will provide a little bit more detail for the group of people who may be moderately and severely immunocompromised in the COVID-19 vaccine. Just as a quick reminder, there is a list of conditions considered to be moderately or severely immunocompromising on the CDC website. I'm not going to list them all to you, but again, reminder, it could be receipt of solid organ transplant, again, such as a kidney transplant, advanced HIV infection, active treatment with high-dose corticosteroids or other immunosuppressive therapies. So again, visit the CDC website to see that exact list. But the 2 points that I wanted to point out about the recommendations here is that the number of recommended updated, so 2023, 2024 mRNA vaccine doses for an individual who is moderately or severely immunocompromised is based on vaccination history and the vaccine manufacturer. So if you didn't get an initial dose of COVID-19 vaccine or didn't finish the series, you may need more than one dose of this updated 2023-2024 COVID-19 vaccine. So a couple of examples, it could be that you didn't get any vaccine doses at all, and you're 6 months and older and moderately or severely immunocompromised. That would actually mean that current recommendations are that you need to receive 3 doses from the same manufacturer, so that you would hear that read as 3 homologous doses of the mRNA vaccine, so all 3, Pfizer, Moderna, etc. Or say you only received 1 or 2 of the original monovalent or bivalent mRNA doses. So that might mean you need 2 or 1 of these homologous updated mRNA doses, respectively. So I don't expect you to have that memorized or anything, but just to illustrate that if you're in this group, it's important, that you understand your vaccine history and that you talk with your healthcare provider to make sure you're getting the appropriate number of doses now. And then kind of on top of that, as we progress through respiratory viral season, further additional doses may be administered, informed by the clinical judgment of a healthcare provider and personal preference and circumstances. And that if that's the case, then those should be administered at least 2 months after the last 2023-2024 COVID-19 vaccine dose. And again, this is specifically for moderately or severely immunocompromised individuals. And I think we'll better understand how this is going to be enacted as we progress through respiratory viral season. So a couple of COVID-19 vaccine questions. The first is if you recently or relatively recently gotten a dose of the bivalent mRNA vaccine, should you get the updated fall vaccine? And the answer is yes. I guess it just depends on the timing. But a dose of the 2023-2024 COVID-19 vaccine dose is recommended at least 2 months after receipt of the last COVID-19 vaccine dose. The next question, will the bivalent mRNA vaccine be available once the fall vaccine is released? And the answer is no. The bivalent mRNA vaccine will no longer be authorized. And then number 3 here on this slide is, can I get other vaccines at the same time as the COVID-19 vaccine? And the answer is yes. Routine administration of all age-appropriate doses of vaccines simultaneously or at the same time is recommended for children, adolescents, and adults if there's no contraindications at the time of the healthcare visit. And then last is, if I don't want to get an mRNA vaccine, can I still get Novavax? And so the answer is generally yes. If you are unable or choose not to get the updated mRNA vaccine, the original Novavax COVID-19 vaccine remains authorized for use as a 2-dose primary series or as a booster in limited situations. And there's a lot of caveats around who can and can't get Novavax, such as only certain age groups and timing since last vaccine doses, so we won't get into that. But just know again that the original Novavax COVID-19 vaccine remains authorized for now and can be given if you're unable or choose not to give an mRNA vaccine. There are authorizations or approvals kind of pending for an updated 2023-2024 Novavax COVID-19 vaccine that will be determined by FDA with CDC recommendations to follow. So again, recommend checking out the CDC website for more information on kind of the currently authorized Novavax vaccine. So switching away from vaccines, all viruses, including the virus that causes COVID-19, change over time. These viruses with changes are called variants. And these changes can affect how contagious a virus is, how well it responds to treatment, and how severely it affects people. So some variants you might have heard about in the news recently is the EG5 or ERIS, which is related to Omicron, so an Omicron descendant. Currently, or as of at least of September 16th, it was a dominant circulating variant in the US. And based on what we currently know, it's pretty similar to recent strains. And given this degree of relatedness, the updated vaccine should have good protection. And the other variant you may have heard about is the BA.2.86. Of note, it does have multiple genetic differences from previous and currently other circulating versions of SARS-CoV-2. But early research data from multiple labs is reassuring and shows that existing antibodies work against this new variant. So these data is very encouraging because of what they likely mean for the effectiveness of the new 2023-2024 COVID-19 vaccines. It is unclear how easily this variant spreads compared to other circulating variants, but at this time, it does not appear to be rapidly increasing or driving increases in infections or hospitalizations in the U.S. CDC provides regular updates and will continue to monitor the effectiveness of current vaccines and other therapies against circulating strains and will adjust recommendations accordingly. This is something that's published pretty frequently on the CDC website, updates like the one I just read, and I do have the link for that at the bottom of the slide. So whenever new information on kind of these current variants comes out, it's a good place to check for the most up-to-date information. COVID-19 hospital admission levels can help individuals and communities decide which prevention activities they can take based on the latest information. For each level, low, medium, or high, CDC recommends actions you can take to help protect yourself and others from severe impacts of COVID-19. CDC updates these levels weekly. You can check for updates for the county where you live or where you may be traveling at the website that's listed on the slide. Just something to note and kind of keep an ear out for. CDC is continuing to explore if there's other available data that can be used to inform actions to protect yourself and others from respiratory virus. And this includes COVID-19, and influenza and RSV, as we've been discussing. And we'll continue to update everyone as we learn more about this data and how it can be used. Masks and respirators are tools that you can use to add another layer of protection. While some offer more protection than others, it's most important to wear a well-fitting mask or respirator correctly that's comfortable for you and that provides good protection. Just remember, you may choose to wear a mask or respirator at any time. Their effectiveness for preventing the spread of different respiratory viruses may vary, but generally masks and respirators can help reduce the amount of germs you breathe in. You can also use masks or respirators to help protect others if you have a respiratory virus. It's important to wear a mask or respirator when you are sick or caring for someone who is sick with COVID-19 or other respiratory viruses. When caring for someone who is sick with COVID-19, a respirator will provide you the best level of protection. When respiratory viruses are causing a lot of illness in your community, wearing a mask or respirator will help protect you and others with kidney disease. For COVID-19, recommendations for masking in public are based on COVID-19 hospital admission levels. As levels increase, the recommendations on masking become stronger. Healthcare facilities have policies on masking. These policies can change over time and can differ across units in the same facility. For example, higher risk areas such as emergency departments or units with patients at higher risk may require masking. Some circumstances healthcare facilities consider when updating or changing their policies include if an outbreak of respiratory infection is occurring in their facility or on a particular unit, or if community levels of respiratory viruses are high or increasing. So you may see at a healthcare facility that you visit frequently, sometimes you're asked to mask, or you may see signs asking others to mask and sometimes not. So just keep in mind that these policies, change as, things are changing with respiratory viruses either in that facility or in the surrounding community. Even when masking is not required by the facility, individuals should continue using a mask or respirator based on personal preference, informed of their perceived level of risk for infection based on their recent activities. For example, attending crowded indoor gatherings with poor ventilation, and their potential for developing severe disease if they're exposed. Remember, everyone with symptoms should use a mask or respirator to protect others, and ensure you are aware of recommended infection prevention and control practices in the facility, including when there are changes in response to new infections in the facility or increases in respiratory virus levels in the community, so you can be engaged in your care and ask questions if needed. The last subject I was going to touch on today is prescription antiviral treatments for COVID-19 and flu, which are widely available and can lower your risk of severe illness, hospitalization, and death if they are started soon after you become infected. Regarding COVID-19 treatments, If you have COVID-19 and are more likely to get very sick from COVID-19, treatments are available that can reduce your chances of being hospitalized or dying from the disease. Medications to treat COVID-19 must be prescribed by a healthcare provider and started within days of when you first develop symptoms to be effective. Check with your healthcare provider or pharmacist if you're taking other medications to make sure the COVID-19 treatments can be safely taken at the same time. If you get sick with flu, influenza antiviral drugs may be a treatment option. Antiviral drugs work best when started early, such as 1 to 2 days after your flu symptoms begin. When treatment is started within 1 to 2 days after the symptoms begin, these drugs can lessen symptoms and shorten the time you are sick by 1 to 2 days. They might also prevent some flu complications like pneumonia. So for people at higher risk of serious flu complications, treatment with influenza antiviral drugs can mean the difference between milder or more serious illness, possibly resulting in a hospital stay. Currently, treatment for RSV is supportive care, as there is no effective antiviral for RSV at this time. Talk with your healthcare provider now, in advance, to understand your options for treatments if you get sick. This can help you access treatment as soon as possible if needed. So on this slide here, I was just going to share some resources to help direct you to the right place on the CDC website for some of the particular topics that we discussed today. I think most of these websites were already listed on the slides where we talked about these particular topics, but I just wanted to kind of put them in one place to point you to what I think are some of the higher priority websites that you would want to be keeping an eye on over time. But again, a lot of other information available on the website, and it's updated very frequently. And so that's it for today. Again, just wanted to highlight what I said earlier, that we did cover some actions you can take to, protect yourself and others during respiratory viral season. But again, we weren't able to touch on everything. So again, just because we didn't mention it doesn't mean it's not an important action you should take. Keep an eye on the website frequently, as we update, as we learn more information, and feel free to email us if you have any questions. Thanks again for this opportunity to talk today at AAKP. I hope everyone has a good meeting.
Dr. Novosad, thank you for sharing insights on the current COVID landscape and what kidney patients can do to be responsible and to be safe. We'll now hear from Dr. John Snyder, Director of the Scientific Registry of Transplant Recipients, also known as SRTR. In addition to his work for SRTR, Dr. Snyder serves as a statistical editor for the American Journal of Transplantation and as an associate editor for the journal Transplantation. He is a member of the American Society of Transplantation and the Transplantation Society, and served on the board of directors of Donate Life America and the Organ Donation and Transplantation Alliance. Dr. Snyder joins us today to share some insightful research that has become available about the impact of COVID-19 on the kidney patient population. Dr. Snyder, I turn it over to you.
Well, I'd like to begin by thanking Richard Knight, our moderator, for the invitation to be with you all today. This is my second time attending the AAKP patient meeting, and I just so appreciate the opportunity that AAKP gives the Scientific Registry of Transplant Recipients to talk with you all and share some of the exciting information and things going on at the Scientific Registry of Transplant Recipients, and just bring awareness to our patient population about the resources that we have available. So Richard and colleagues invited me to speak today on the COVID-19 pandemic a bit, ongoing threats to vulnerable kidney patients, and current research on long COVID. I'm going to really step back from that a bit as we begin and just share with you a bit about what's going on at the SRTR, and then I'll get into some of the COVID monitoring and resources that are available for our patient population. By way of background, I am the Director of Transplant Epidemiology at the Hennepin Healthcare Research Institute. We are located in Minneapolis, Minnesota. As our team operates many things, but one of the things we do is we operate the Scientific Registry of Transplant Recipients, and this is a federal contract with the Health Resources and Services Administration, and I'll tell you more about that in a moment. I'm obliged to say that the views I express today are my own and do not necessarily reflect the official policies of the U.S. Department of Health and Human Services, nor does any mention of a trade name or commercial practice organization imply endorsement by the U.S. government. Once we get that out of the way, I'm pleased to have a few associations. I serve on the board of directors of Donate Life America, helping to spread the word about organ donation in our country. I also serve on the board of directors of the Alliance, which is an educational association educating professionals in the field of organ donation and transplantation. And I'm also proud to serve on the clinical policy board of LifeSource. LifeSource is the organ procurement organization that serves Minnesota, North Dakota, and South Dakota. A bit of background about the SRTR. This is a federal contract that is held within the U.S. Department of Health and Human Services. Within U.S. Department of Health and Human Services is the Health Resources and Services Administration. And within their division of transplantation, they put out two major contracts to support the nation's transplant system. The first on the left here is the Organ Procurement and Transplantation Network, or the OPTN. That contract is operated by the United Network for Organ Sharing, or UNOS, in Richmond, Virginia. And I like to think of our position in this as a sister contract to the OPTN contract. The Scientific Registry of Transplant Recipients on the right is operated by Hennepin Healthcare Research Institute in Minneapolis. Our role in this system is to essentially serve the system with scientific research, data analysis. Our team supports the policymaking bodies within the Organ Procurement and Transplantation Network at UNOS with analytics if the committees need data to make the best decisions they can make to inform their policy choices. We supply those data analyses to the committees. We're proud to do so. You can find our main website at www.srtr.org. And we have a number of resources there. I'll show you how to get to probably the most relevant resource for you at the moment. But here's just some imagery of two of our major reports. On the left side, where we have our organ procurement organization statistics, you can see the map of the country there. Each of the 56 current organ procurement organization service areas are shown in the colors there. And you can click on any one of those and be taken to a report with a number of data points about the organ donation operation within those service areas. Probably more relevant to our patient population is on the right side. We do offer reports of every transplant program in the country, and these are updated every 6 months. I'm showing here just the homepage report of the Ohio State University Medical Center. Just chose this one at random for you. I'll show you a bit about how to access this, but within these reports you can find a lot of information about the numbers of patients on their wait list, the outcomes for those patients on their wait list. We have some data about the program's offer acceptance practices, their waitlist survival, their post-transplant outcomes as well. And you can look at this by adult and pediatric patients for many of the statistics as well. I'll show you a bit more about how to access that next. So here we see an image of just the top of our website, and this is where you can search for a particular transplant program data. And right in the header of our website, you'll see this Find and Compare Transplant Programs page. I've pre-selected kidney here, but you could search for any organ type that we have available. And then in the search box to the right, where we have search for a by postal code or by program name, this is optional. If you wanted to put in a zip code near your home, for example, and search within a radius of that location, you could do so. If you wanted to type in a hospital name, we could search by that. Or you can just leave this blank. If you just leave this blank, the system will perform a national search, which is what I've done here. So if we click on search, you will be presented with a list of programs that are initially sorted by which programs have the best results for getting patients transplanted quickly. And you'll see that by the highlighted column second from the right that has a little indicator on it. That is just indicating that we're currently sorting by that column. And so this was a national search, and so we currently see the program that floats to the top is New York University Langone Health, New York City, followed by University of Florida Health, Shands Hospital, and so on and so forth. I'm just showing you the top two. You can go down the list. Notice in the distance column in the middle, we have not applicable. That is simply because I did not search by a zip code. If you had searched by a zip code, you would see results there, and I'll show you that next. So here's an example where I put in the zip code, just randomly picked one of Washington, D.C., zip code 20002. And so what's happening now is we're looking within a radius of that zip code. So now the top hospital that pops up is Johns Hopkins Hospital in Baltimore, and you can see their results there, how far that is from the center of that zip code, followed by University of Maryland Medical System. And again, these are going to be sorted by the programs with which are getting patients transplanted the fastest and have the higher volumes if they're tied. And you can see results there for first-year kidney survival post-transplant as well, and how many transplants they've performed. So if I back up and click into the first program I showed you was New York University Langone Health, you would be taken to a page that looks like this, that just simply begins with a map of where the hospital is located. You can view the hospital's website, and there's some other contact information there. You can download a PDF printable report, or you can just navigate through the report as well. You'll notice at the top of the screen in the middle, I have the icon with kidneys where it says kidney transplants. That just indicates that we are currently looking at New York University's kidney transplant program report. And see all of the other organ icons to the right. These indicate the other types of transplants that this hospital performs. And you could quickly, if you were curious, switch to their, for example, their heart transplant program and see results for that program as well, or their lung program or liver program, etc. But of course, today we're talking about kidney transplants, so we'll stay here. You're first presented then with a simple summary. This replicates much of what was on the original search results. How many transplants have they performed in a recent year from both a deceased donor as well as living donor, and what were their outcomes in general compared to other transplant programs for their waitlist survival, how fast they're getting patients transplant, and their first year kidney transplant outcomes. This defaults, of course, to the adult transplant population, but you can switch it to the pediatric by clicking the Show Pediatric button as well. That is followed by a simple display of what's been recently happening with their wait list. Here we see they had 535 people awaiting a kidney transplant as of the January 1st of 2022. And then you can see we present movement on the list during that year all the way through December of 2022. And so we can see that they added 346 patients to their list in that 1 year period, and they removed 417. And you can look below for the reasons for removal. Of course, what we're looking for is the 60 that received a living donor transplant. 273 of them received a deceased donor transplant at this hospital. 23 unfortunately passed away, and 5 were transplanted at another program, etc. You can see the results there. And there's more data available on their waitlist experience as well. We do present a simple slider if you wanted to look at what fraction of the center's waitlists are transplanted within a certain period of time. Here I'm showing you on the slider here, it goes 30 days, 1 year, 2 years, and 3 years. Those are the choices we have available for looking how quickly patients are being transplanted. And what this shows you, you could move that slider around, but at 30 days, where I have it here, this center transplanted about 10% of their list. Whereas nationally, that's about 4.6% of the list is being transplanted. You can see that this program has a history of transplanting patients faster than what we're seeing happen nationally. We do have some offer acceptance information there. These statistics are a bit more complex, but is essentially trying to give patients an understanding of the likelihood that this center is accepting offers relative to the rate that their peers are accepting offers. And, you know, we're always happy to walk people through these metrics. You can always contact us at srtr@srtr.org, and I'll have that contact information for you. We're happy to help you understand these metrics. But essentially what this is showing, you'll see on the right here, their overall offer acceptance rate ratio is 1.8. Essentially what that means, numbers above 1 indicate that they're accepting offers at a rate that's higher than national average. And if it was below 1, it would be rates below national average. So a 1.8 essentially means that based on the types of offers this program is receiving and the types of candidates they have that are receiving those offers, this program accepts offers at a rate that's 80% higher than their peers for similar offers to similar candidates. And so that just indicates that this program tends to be aggressive in accepting and transplanting their patients. We do have a number of outcomes metrics post-transplant available that you can find in the report. Here I'm showing you in the green box to the left, there's a bunch of choices you can make. I'm currently showing you their adult 3-year post-transplant outcomes for all kidney patients that received either a deceased donor or a living donor transplant. If you wanted to just simply look at your living donor outcomes or deceased donor, you could choose that there. And then the survival results drop down at the bottom left. You could choose if you wanted to look for what we call graft survival, that is indicating if the transplant itself is still functioning at 3 years and the patient is alive. Or you could switch it simply to patient survival, which is just simply looking at whether or not the patient is alive at 3 years, regardless of whether the transplant is still functioning. And so here you can see we present this in a hazard ratio. Again, numbers above 1 would indicate increased failure rates at 3 years. Here you see a value of 0.69 to the right. And essentially below 1 is good, right? So this essentially means that this program's failure rate post-transplant in the first 3 years is about 30% lower than national average, which is good. So this program tends to transplant patients quickly and is demonstrating good outcomes for those transplants. And this is just an example of the types of data you can look at within our reports. And again, we're happy to walk you through any of these data. We have been on a journey at the Scientific Registry of Transplant Recipients to engage the patient voice more directly. Perhaps some of you listening, I know Richard was there. We hosted a consensus conference in Minneapolis last summer where we had about 25% of the attendees were patients. We've been really trying to find ways to better engage with the patients and hear their voice in terms of the type of data that would be most useful to them as they navigate the transplant system. I just wanted to highlight a few opportunities. We have oversight committees that help us in a more formal way, even outside of engagements like our consensus conference. We call this our SRTR review committee, which is made up of a main committee and then 3 subcommittees, one of which is the Patient and Family Affairs subcommittee. And this year, fortunately, we've instituted a new call for nominations process, which is open now as we speak. It is open until October the 6th of 2023, and we are seeking 5 members from our patient and family population to help us to engage with us, maybe a quarterly meeting or people we can bounce ideas off over email to really understand what our patients are wanting to see and the types of presentation of data that would be most useful to them. So I'd encourage you, if that sounds like something you would like to do, just visit www.srtr.org and right on the homepage, you should see a link to find the application materials for that opportunity. So I wanted to make sure I highlighted that for you. Richard Knight, our moderator today, has served on this committee and has been the chair of our Patient and Family Affairs Committee, and we're so thankful for his service. So I mentioned navigating the transplant system, and this is a map that we've developed, and it's reminiscent of a subway system map, where we have the patient's journey represented by the middle subway line, the light blue line from left to right. And what we've tried to represent with this is all of the players that are involved along the patient's journey to find that transplant, get that life-saving organ to them, and get that transplant performed. So all the way on from when the patient is just maybe initially diagnosed and considering transplant at stop A, all the way down to long-term survival on the right at stop L. And we have, of course, the deceased donation system represented on the top of this in the oranges and browns, and we have the living donor represented in the yellow at the bottom, and all of the other players that come alongside you on this journey. The reason we've done this is we've looked for ways to use these stops on the subway map to identify areas of information or data that we could present to patients to help them understand what happens at these different points along the way. If there's data we can provide, how can we best do that for you? Or if there's a stop where perhaps we don't have a lot of data, can we point you to where you could find that information? So we have really rallied around this system map as a way to go forward at the Scientific Registry of Transplant Recipients and develop tools and resources for you. I'll show you some of those next. So we have a new website in development, and we are calling this effort our patient-friendly website initiative. And Essentially, we are using that system map that I just showed you to really be the guiding light for how we present information to transplant patients. And so you can see here an image on the left that would be a place where you could look around on that system map and maybe use those subway stops to click into and find targeted information about that point in the journey. The images to the right are just meant to show how this would look on your mobile device. We're working very hard to make sure that any presentation of data that we offer you will work well on either your computer or your mobile device and be really targeted to helping you quickly find the information that you're looking for. This is an example again of what this might look like when you're looking along different stops. If you click on the time of listing, a little pop-up might come up, and the text here that's in here now is simply placeholder text, so don't get hung up on that. This is in development, but the box that pops up would give you some information about the listing process and then give you immediate links to where you can go find better information, whether that's on the SRTR site with data that we can offer you, or if we can link you out to other trusted resources, we will do so there. So we're excited to bring this to you, and you can see again on the right how this may look on your mobile device, but the functionality should work similarly. So we're working hard to make this reality. Okay, deep breath. Richard asked if I would just mention some resources for you about COVID-19. SRTR has been tracking, of course, the COVID-19 pandemic from its initiation back in 2020. We do have some information available, but I also just wanted to make sure that you were aware of other trusted sources, namely the one that I tend to gravitate toward myself when I'm looking for the most current information that's available is from the American Society of Transplantation. They have a website. I've offered you the URL there at myast.org. And I think that this gives a number of resources for patients that we'll look at just briefly here. So here we see AST's resources for candidates and recipients. This is, again, right on that same website that I just showed you. There's current vaccine information for transplant patients. This is updated regularly. When I created this slide, the most recent update was in March of this year. There's COVID-19 handouts for recipients and candidates. There's COVID-19 FAQs, frequently asked questions for transplant candidates, recipients, and caregivers. In addition to the patient resources that are there, they have resources for professionals as well. Those are available to you if you have interest in looking at some of that more detailed information. That is there as well. But in my view is my go-to for where I find the most current information. But I do want to show you a few things that we've been looking at the SRTR. We have been monitoring this, and this monitoring application is available on the SRTR website. It's under our tools menu. You'll find a COVID-19 monitoring application where you can really go through a lot of very detailed data. And I just pulled a couple examples where we can just look at what happened in kidney transplantation as the pandemic rolled along. The dashed line in the middle here is the first month of the pandemic in March of 2020. And what we're showing here is simply the number of kidney transplants that were performed. The top blue line is the total number of kidney transplants, and that's divided out below in the red line, which is the living donors, and the green line, which is the deceased donors. And you can see how this impacted living donation most substantially. The red line had a very significant drop in March and April of 2020. And thankfully, that quickly recovered, and we saw this in both the deceased donor population as well as the living donor transplants for kidney patients. We saw this recovery quickly as transplant programs figured out how to navigate during the pandemic and continue operations. And so we were pleased to see that recovery happen. Living donation, though, as you'll see, the green line and the red line were disparate before the pandemic, and they've been very much on top of each other after the pandemic. So, living donation, I think, still continues to struggle a bit in the post-pandemic period. So that's something we're watching carefully. This is just another way to look at the same information. We have internal tools that we're tracking the pandemic here. So again, you can see the effect on deceased donor transplants plotted over time. These are just running daily averages of the number of transplants performed. And so you can see when COVID-19 struck there, that's their first red line, you see this drop off quickly and then a recovery. You can see drops during subsequent waves of the pandemic. Those show up. I don't have those marked here. The CAS 250 red line is when the new kidney allocation system went into effect. And so we just put markers like that in our internal tracking tools where we can see significant events in the kidney transplant system. So we can mark those as we consider what's happening. But these other dips you see here are mainly due to the other waves of the pandemic as well. And here we see again the same idea, but what happened with living donor transplantation in kidney. Again, a more significant drop immediately after the COVID-19 pandemic began. Recovery quickly into the summer of 2020. We see dips at the significant next waves of the pandemic, of course, when living donors were perhaps not being scheduled during those waves of the pandemic. But again, this trend unfortunately is flat. We'd like to see this continue to find a way to start to increase again, and it's something we continue to watch. So we also have been tracking what's been happening pre-transplant. So what's been happening on waitlist deaths during the first 2 years of the pandemic. And essentially what happened in our kidney transplant candidates as they're waiting for transplantation greatly mirrored the basic death rates that you saw in the general population, right? So now we're looking at our dialysis population, and you can see the green line is the first month of the pandemic, when the pandemic began. And then monthly, we have monthly dots as we're going forward. And you can see each of those upticks in this is when there were waves of the pandemic rolling through. And so we're continuing to watch this as well. Of course, these are just counts of deaths per 100 person years on the list. And so we continue to watch this as the pandemic rolls forward. I wanted to highlight this paper, and I have the reference at the bottom of the screen. This was Dr. Mohan at Columbia University in New York, who published his analysis of what's happening with deaths. And he was looking more granularly at the excess deaths that we're seeing in what we're showing here is the kidney transplant waitlist population. So patients that are awaiting transplant. And the blue area, the blue part of this plot is the total number of deaths that we saw in 2020. And of course, the big first spike is the first wave of the pandemic. And you see perhaps subsequent waves rolling forward through that year. And the two lines through that middle are the prior 2 years, just to give you a sense of what was happening in quote unquote non-pandemic years, what this should have looked like. And then the red at the bottom represents what we thought to be, or what Dr. Mohan thought to be in his analysis, the excess deaths that we saw that could be attributed to COVID-19 in that population. And I say could be as simply was looking at how many excess deaths were we seeing relative to what we thought we'd see given the trends in prior years. And so I think it's a nice way to think about how the pandemic impacted our waitlist population. And then on the next slide, I'll show you the transplant population. Yeah, so here we see what happened, the same type of idea, same type of plot. The red represents the excess deaths that COVID-attributed deaths happening in our post-transplant population across those weeks post-pandemic. And so you can see a substantial red area there, and so we're continue to watch this as well. One of the challenges that we have in the National Transplant Registry is just what is the capture of deaths, and this is something that we have been studying. Deaths are reported by the transplant programs. They do report in a cause of death if they know a cause of death in their patients. And so in this project, we simply recently published this in the American Journal of Transplantation just earlier this year, where we looked at comparing what was reported in the National Registry to what we saw in the CDC's National Death Index. The National Death Index captures the cause of death from the death certificates. And so we thought it would be an interesting analysis to ask the question, what is the accuracy and completeness of reporting of COVID deaths, and how can we use the National Registry to even understand this in a more granular way? So I'll show you some of those results on the next few slides. So here's a quick analysis, and I'm going to start by just focusing your attention to the left here. In the SRTR, at the time period studied, and you'll see that at the top, June to December of 2020, we're looking initially when these deaths first started being reported in the National Registry was in June, so there was about a 3-month lag in the ability to report these deaths into December of 2020. And so at that time, we had 1,421 SRTR reported COVID deaths. And what we did is we compared that to approximately just over 11,000 deaths in the SRTR registry that did not report COVID as the cause. And then we merged that all to the National Death Index and pulled the cause of death from the National Death Index to see how well these matched up. So here at the top, I'm calling this the true positive rate. So of those 1,421 SRTR COVID deaths, 1,370 of those, 1,370, were confirmed by the National Death Index. And so we're saying that there's a 96% true positive rate. If COVID is reported to the SRTR as the cause of death, that is likely accurate. 51 of those were not confirmed by the NDI. And so here we see that this was a 4% false positive rate. And so this assumes that the national index got it right as well. Perhaps the transplant program was correct, but of those 1,421 SRTR COVID deaths, we did not find COVID listed in the death certificate for only 51 of those patients. So overall, we feel like the sensitivity, if it's reported as a COVID death to the SRTR, most likely that is a true COVID death. But how about the deaths that weren't reported to the SRTR as COVID? So those 11,000 deaths we looked at that were not reported as COVID, we found that 1,394 of those had a COVID indicated as the cause of death in the National Death Index. And so we've labeled that a 12% false negative rate. And conversely, if it wasn't a cause of death, we found that 88% of the time, NDI also said it was not a COVID death. So that'd be an 88% true negative rate. So this gives us a sense of what the accuracy is. And in summary, when we look at it in total, this is the way I like to describe it. Of the NDI indicated 2,764 COVID deaths, whereas the SRTR only had an indication of 1,421 of those in the deaths that we sampled. And so my conclusion from that is we're only capturing about half of the COVID deaths in the SRTR data set. Now, I think we can continue to look at COVID in the SRTR data and we're, see how, if this is improved over time, hopefully. But right now, I think it gives us a bit of pause that we know that there's probably underreporting of COVID deaths by the transplant programs. And so this just helped us informed when we're looking at these types of data, what we can really learn from this information. So while I wish we had 100% capture, I think it's useful to put it in context, what we see in the data set. Well, again, I want to thank Richard Knight and the AAKP for offering me the opportunity to connect with you. Here are some resources for you if you want to get involved, you want to stay informed. Again, I encourage you, if you're interested in helping us more directly, to look for that opportunity on our website to connect with our scientific review committee and our patient and family affairs committee. I encourage you to apply if you have interest in that. Other than that, I will turn it back to Richard, and thanks again for the opportunity.
Thank you, Dr. Snyder. As we often find with research, there's always more to learn. Sometimes our findings lead us to more questions than answers. We appreciate you sharing this information with us because being informed is a powerful tool to remain safe. Our next speaker is a good friend of AAKP's who's been gracious enough to join us for several AAKP events, Dr. Lisa Glasser. Dr. Glasser serves as the head of the U.S. Medical Affairs for Vaccines and Immune Therapies at AstraZeneca. She possesses a wealth of knowledge and expertise in vaccines spanning different age groups and brings a unique perspective from clinical, commercial, policy, and public health standpoints. AAKP has been proud to collaborate with Dr. Glasser and AstraZeneca to promote awareness of the potential new treatments for vulnerable people like kidney patients. Dr. Glasser joins us today to discuss AstraZeneca's current efforts in the COVID-19 space. So let's hand the program over to her and learn more about their incredible work.
Thank you, Richard, and thank you to the AAKP for having me here today. It's my pleasure to be here on behalf of AstraZeneca and to share with you a little update on what we are doing to keep our eye focused on important patient populations like people with kidney disease, people who've had transplants, and in general, the immunocompromised patients. AstraZeneca is making progress in our vaccines and immune therapies portfolio, and we have an ambition to deliver long-lasting immunity and protection against infectious diseases that affect millions of people around the world. We recently received FDA approval for Beyfortus, which is known as nirsevimab, which is the first and only single-dose RSV immunization specifically designed to protect all infants through their first RSV season. This is a major milestone in the prevention of RSV disease for babies, and Sanofi will be commercializing this product in the United States. The technology for monoclonal antibodies and the institutional knowledge on this subject is very deep at AstraZeneca. We brought Evusheld, which many of you may have heard of or even received, and we are hard at work to rapidly advance our next generation antibody, AZD3152. We aim to make it available as a new option for COVID-19 prevention by the end of the year. Of course, subject to trial readouts and regulatory reviews, starting with an emergency use authorization in the United States. There is an ongoing need to protect vulnerable patients, such as the immunocompromised, who have no other option for prevention of COVID-19 besides vaccines, and we know that many of them do not mount an adequate response to vaccines and are inadequately protected. These individuals are at risk for severe disease and poor outcomes and interruption of the care for their primary condition. We're working on next generation technologies to develop vaccines and monoclonal antibodies for infectious diseases, where there's a high unmet need. As a part of this work, we are actively investigating opportunities to advance antibodies to tackle serious bacterial infections and antimicrobial resistance. The clinical trial to support the new prevention for COVID-19 monoclonal antibody AZD3152 is on track, and it's called Supernova. Many of you have heard about it. As I said, we hope to make this available to patients at the end of this calendar year. We know that despite the desire of all of us to be finished with COVID, it's not finished. And clearly making the news now as we head headlong into the respiratory season is that COVID cases are going up, hospitalizations are going up. And we know that individuals who are immunocompromised and individuals who have high end-stage kidney disease on dialysis bear an undue burden from this infection. AstraZeneca has now published research through our EPOC study, which is a real-world evidence study looking at the burden of disease in immunocompromised patients for COVID-19 and hospitalizations, and the economic burden as well. We are continuing this research and will be soon publishing the second iteration of the project, in which we look throughout the totality of 2022 at the burden in these populations and again at the economic burden. And one thing that stands out is that individuals who have CKD stage 5 or are on dialysis are a real outlier on their burden, both in terms of COVID-19 infections, severity of infections, hospitalizations, and severe hospitalizations requiring ICU and high levels of care. These are obviously associated with high cost as well. Be happy to share with you, once this data is published, a link to that study. AstraZeneca has made a commitment to prevention of infectious disease with a complementary strategy of active immunization with vaccines and passive immunization for those who need it with monoclonal antibodies. We are focusing on infectious diseases with high impact and in patient populations of high unmet medical need. We are actively working on all of these projects and are partnering with groups like the AAKP to help educate and to help us understand these populations and the communities in which they live so that we can produce interventions that are helpful and educate the healthcare professionals and the patients and their families themselves so that the best care can be delivered. One of the most important things we can do is prevent infectious disease. It causes a huge burden for all of us and to our healthcare system, and AstraZeneca has made a commitment to that effort. I want you to know that we stand with you, that we are looking out for your interests, and we are so glad to partner with you. I thank you for the opportunity to speak to you today, and I'll turn it back to Richard now.
Thank you, Dr. Glasser. We appreciate you sharing what you and your team at AstraZeneca have been doing in the COVID-19 space to advance research and bring therapeutics to those who need them. Finally, we have my good friend, Miss Della Major. Miss Major is a dialysis patient from Illinois and is someone I've worked alongside on many kidney initiatives. She is an AAKP ambassador and founded Living Your Life Victorious and Empowered, a patient empowerment organization. Della has fought many battles in her kidney disease journey, including COVID-19. She joins us to share her personal battle with COVID and its continuing effect on her life. Della, I turn the presentation over to you.
Thank you, Richard and AAKP, for this opportunity to come and share a little bit of my journey and my story about long COVID as a kidney patient. You know, I actually was diagnosed with COVID-19 in February of 2021. And throughout that stint in that time, I had several difficulties. And it was over a period of 3 months of just really dealing with not only just the pain, but also dealing with some of the other additional complications that occurred based off of that particular disease. One of the situations that really happened was I not only had contracted pneumonia, which was which you might say a symptom of the long COVID. But throughout that time and over the period of 3 additional months, I had major issues with my respiratory. Pretty much I was given a spirometer, and then having to take that, I was diagnosed with a mild case of lung disease. One of the things that people don't understand as a renal patient, our immune system is already compromised due to other situations and issues. So contracted COVID did not help me in the long-term sense of things, because at that time I had just recently, in August of 2019, received a kidney transplant. And so dealing with not only the complications of COVID the following year and a half, it also caused me to have other major complications with my actually transplanted kidney. So due to the result of that, now I'm back in center dialysis. One of the things that I found that was really intricate, that was really interesting, that my doctors was telling me, is that the fatigue. I've already had somewhat like a poor sense of appetite, but dealing with the symptoms of COVID-19, not only did it make that even more severe, but the fatigue. I was so extremely tired. Basically, I was barely able to walk a simple block. And over dealing with the fatigue, even right now, I'm still dealing with that. And it's one of those scenarios where the doctors is trying to work with me in getting me more mobile and movement, but yet still I find myself dealing with that, as well as just trying to have a good sense of breathing. The hoarseness and the raspiness came as it relates to that, because it was very difficult with the strong coughing that I had. So, as a kidney patient, we pretty much deal with a lot of things, but COVID-19 is just one of those illnesses where that you will find you have those additional challenges. And so when I heard about the long COVID and the other additional symptoms like the brain fog, the memory challenges that I was having, it made me realize that, this was not a simple feat of just getting the Regeneron, the actual medication. But even now, I'm currently still dealing with that. But I'm still encouraged and I'm still empowered and inspired by the fact that I can still keep going on. Although my kidney transplant has failed and now I'm back in in-center dialysis, I'm yet still encouraged that we, with the new innovations and, of course, the researches that's still going forth and helping us to really truly understand long COVID and in understanding the effects that it have on kidney patients, that we ourselves will be able to be encouraged that something will happen and some new innovation, some new medication will come along outside of just the standard vaccination, because I do encourage kidney patients to get the vaccine and to get vaccinated. That definitely helps us to be able to really have some sense of strength and some sense of fighting agent, you might as well say, to help us to deal with this. COVID-19 was just one of those pandemic diseases and situations that nobody can even anticipate. But yet, I'm still moving forward and I'm still encouraged as to what can really, really happen. So I want to thank Richard Knight. I want to thank AAKP for this opportunity to really just share a little bit about my journey of dealing with COVID-19 as a kidney patient. So thank you again.
Della, thank you for being with us today and having the courage to share how COVID-19 has affected your life and how you continue to cope with long COVID. With that, I again thank all our speakers and thank everyone for joining this session. Please read the statement AAKP issued about the ongoing threat of COVID-19 to vulnerable kidney patients, which we have included in this platform.